So good morning, ladies and gentlemen, and welcome to this first breakout session from TIO 2024. This session is entitled The Future of Vascular, Large Bore Closure and Best in Practice Management. My name is Darren Mylotte. I'm an interventional cardiologist from rainy Galway that you see in the background of your screen. And I'm delighted today to be joined by two friends, great colleagues and master operators, Liesbeth Rosseel from Belgium and Ole de Bakker, also from Belgium, but currently practicing in Copenhagen. So good morning, guys, and welcome to TIO 2024. We've got a really interesting topic today, and what we plan to discuss over the next 55 minutes are the essential techniques and a review of current devices and the landscape of large bore vascular closure, specifically for TAVI, but we're also going to touch on venous closure towards the end of this 55-minute session. Liesbeth is going to take us through the multi-close algorithm, an algorithm that I've started using in Galway actually on a day-to-day basis that I think makes large bore closure more effective, safer, more efficient. And so Liesbeth's going to tell us about that. And then Ole is going to give us some insights into the new PerkSeal device from Vascular that is hoping to change the landscape of large bore vascular closure devices. He's going to show us a recorded case from his center, and we'll see whether this device really has the capacity to be integrated into our daily practice. But without further ado, why don't we kick off with you, Ole? You're going to give us a feel for the landscape of current devices and what's coming for the future, how we need to improve and where the field is going. So take us away over the next few minutes, please.
Yeah, thank you, Darren. And also welcome to Liesbeth, of course. So indeed, I think I take the next 15 minutes or so to just create the context about large bore closure devices. Why do we need it? And which devices are we using? Yes, so I will going to the next slide here. It's not responsive for now. Yes, okay, good. So if we look, why do we really need large bore closure devices? I think most of it goes back to the explosive growth we've seen in TAVI. In the left-hand side of the slide, you see the number of TAVI procedures performed worldwide. And as you see nowadays, in 2024, we are performing around 250,000 TAVI procedures worldwide. So even if we go back just 10 years ago, we were only doing kind of 40,000 of these. So this is a massive growth. And as TAVI is performed typically using between 14 and 20 or 22 French arterial access sites. So we need a good large bore vascular closure device. That's one of the explanations why we became so interested and have so much need in vascular closure devices. Of course, on the right-hand side, you also see why do we also need it. We also use in some centers still from time to time intra-aortic balloon pump. We don't here. We then use Impella device, for example, or mechanical mechanical ventricular support systems, which are also slightly on the rise, I would say, in use. So clearly, we need vascular closure devices. So if I go then to the next slide, there's a small delay in this, but then, yes, as you see here, on the left-hand side, you see when do we really have to use some kind of vascular closure device? This is from a review article, and I think it's rather correct that to say if you use a 6 French access site or larger, you actually have benefit from using a dedicated vascular closure device. If you're using only a 4 or 5 or 6 French sheet, you could still, for sure, for a 4 and 5 French, you could just do the manual compression. Or very often you can just go radial, of course, if you only need a 4, 5, 6 French access site. But if you use, for sure, larger than 6 French, you have benefit of using a dedicated vascular closure device. On the right-hand side, you see, and that's also reflecting my own practice, in the early days of TAVI, the device that was used the most was actually the ProStar device. This was a suture-based device, rather complex, I would say. So this was, the complexity was high with a lot of needles. This was the learning curve was quite high, but that was a device which was used by most centers in the really early days. I'm talking about 2008 to 2000, maybe 12, 13. Then after that, ProStar was abandoned by most sites and was replaced by the double ProGlide approach. And then, of course, we also see on the more right-hand side then the introduction of this Manta device, which was a plug-based, a larger plug-based closure device that has also had seen some adoption in some centers, and still some centers are definitely using this. This was all in an attempt to make it easier. So you see it goes from complex to more easy devices for vascular closure device up to 2022 French bore sizes. So then if I go then to the next slide, then what do we need from, or what do we expect from large bore vascular closure devices? Well, first of all, we want ideally a successful deployment with immediate hemostasis in the absolute majority of cases. And that's something important. If we sometimes use only suture-based devices, what we see is we have a relatively good hemostasis, but not an immediate complete hemostasis. So what you tend to do then is very often either use an additional closure device, a plug-based closure device, or sometimes manual compression. But as the volumes become this high and your flow in your cath lab gets delayed, these kind of 10-minute manual compression in the groin, if you have to repeat this for 4 cases a day, you lose 40 minutes in your cath lab, which is almost the same as saying you're gonna be able to do 1 case more or less that day. So we want immediate, complete hemostasis. That's what we ideally want. Also, we want to decrease the device-related major vascular complication rate to less than 1%. And that's also really the benchmark. I think you have to put yourself in your own center. You really have to try to bring that major vascular complication rate down to 1 or less than 1%. I think then you're doing a good job. And which device to be used for that, or which techniques, we will discuss in the next couple of 45 minutes. Then there's the third point is versatile to adapt to difficult anatomy with minimal manipulation and alteration of the vasculature. That's of course also an important point. That was, for example, with the ProStar in the early days. I think it was that complex, that many steps to deploy the device. We do not want this ideally. We want a very easy device to deploy, very easy to learn, to adopt. And then also the alteration to the vasculature at the end. We don't want to necessarily leave a large footprint behind in this vessel. We want to do this within as minimal and small footprint, and also something ideally that can absorb after some time. Fourth point is universal application leading to minimal exclusions or screen failures. I think this is more about how versatile is your device indeed to be adopted. If your device works well in 60-70% of your cases, but is not really ideal because of different reasons, either it needs a large vessel size or it needs absolutely no calcium whatsoever, then of course it also makes the adoption in an all-comers population really difficult. So ideally you want a device which is rather forgiving for these kind of parameters. We also want a single device, ideally that should be capable to achieve adequate hemostasis. That can be discussed, and that's going to be interesting to see what, with the algorithm that's going to be discussed by Liesbeth Rosseel about the multi-close there. It's actually coming away from that we need this single device. It's maybe more that it's even a benefit that we can combine a couple of different techniques, but we come back on that later. But ideally, in the ideal world, you would have just one single device that gives you immediate, full and reliable hemostasis in an all-comers population, of course. The next point is easy to use with predictable and reliable closure. Of course, that's what I said. We want a predictable result and reliable. It should be easy to repeat. Another point, affordable and cost-effective. Of course, all these vascular closure devices, they come with a cost, clearly. And of course, if you have to combine sometimes multiple devices, this can give you an additional cost. Or if one device is more prone to fail than the other, you maybe have to also incalculate the cost that it gives you that you have to use maybe a little bit more balloon, or maybe in some cases a covered stent. So these costs have to be taken in its totality to make a real correct assessment of what is the real cost of a certain approach to close your vessel and have successful closure at the end. It should be able to readily re-access the arterial site post-closure. That's also an item, of course. How fast can you re-access this vessel after leaving the closure device behind? We can discuss this later as well. And then, of course, this is an important point. I think in current TAVI practice as well, we want a device which makes it possible for the patient to early ambulate, the early mobilize. And even from sharing here in Copenhagen, for example, our experience is that we want ideally our patient to mobilize and get out of his bed 3 hours after the procedure. Because if we don't succeed in doing this, it's basically almost impossible to send this patient reliably home, discharge him the next day. So this early ambulation is also something we really want to obtain, and it's important that we can get this with the closure device. So then jumping to the next slide, you see here, this is the major vascular complication rate that we see going down over historically from the partner one, going from 20-25% complication rate, major vascular complication rates, to in current practice, I would say in most practice it's below 2 or 1% ideally, but even in the low risk trials like the Evolute low risk trial, you see a major vascular complication rate of around 2.4%. I think that's rather acceptable. That's of course has to do with a lot of different factors. First, the technology improvement, so the devices come in smaller bores, so they need less space. We become more experienced as operators. And lastly, also we become better in pre-procedural planning and previewing, predicting whether we're going to have a difficult access or not. So next slide then. Impact of vascular complications. I think it's still important, vascular complication. This is one of the only reasons why a patient sometimes stays longer in the hospital or has some additional post-procedural complication besides than the conduction disorders. But this is the only complication that really is also linked to increased mortality, poor quality of life. There are good data and evidence on this. And of course, it also has a significant economical impact. These patients, if you have a vascular complication, they stay longer in the hospital, gives an extra cost. There's an extra cost of care also. So this is something we really can and want to avoid vascular complications. So next slide then. If we go there, this is to give you again more in detail the devices that have been used in this overview. So typically in the beginning, most centers were using this ProStar, which was with 4 kind of needles, which were shoot out, and then you had to individually retract these needles. Was time consuming, not always reliable, very prone to fail in calcified environment. So this was replaced and more with the double ProGlide technique, and now many centers are going to the single ProGlide, and that's going to be integrated in the MultiCLOSE algorithm. And then you see on the right-hand side, that's the MANTA device. That's the large bore plug-based device where there is a plate in the intravascularly, endovascularly, and then with a large kind of collagen plug on the outside of the vessel to plug the hole. Yes. So next slide. And then I think this is one of the last slides I want to show. This is a nice study done by the Rotterdam group. You see they compare closure with the MANTA device versus closure with the ProGlide device in the TAVI setting. The primary endpoint of this study was a composite endpoint of access site-related major or minor vascular complication at 30 days follow-up. You see this was higher with the plug-based MANTA device as compared to the ProGlide. Also, there were hardly any major or no major vascular complications in the ProGlide arm versus there were 2% of major complication in the MANTA arm. But then if you look to the modified vascular closure device failure rate, this was higher with the ProGlide as compared to the MANTA. Of course, if we look to the endpoint, we have to see what in that endpoint there was failure to achieve hemostasis within 5 minutes or requiring additional endovascular maneuvers such as endovascular stenting. Of course, that's something we want to avoid. Surgical techniques, that's something we absolutely want to avoid, or additional closure devices. And of course, that's why the rate in this ProGlide arm was relatively high, because very often this ProGlide device or suture-based closure is very often combined with a small plug-based closure device. But as said, also that is going to be discussed in a multi-close. So next slide, the last slide. That's just to introduce you. I will not go too much in detail, but there is a new kit on the block for this large bore closure device closure, and that's the PerQseal vascular closure device. We have a dedicated 10 minutes to talk about this at the end of this session, so I propose we do it there. So now back to you, Darren, and we can, if there's some time, we can discuss even this more in detail.
Ole, that's a great presentation, and thanks for the overview. I wanted to say to the 150 or so of you guys who are online, please submit your questions underneath the screen in the text box, and we can get those questions to Liesbeth and to Ole and answer those for you. Ole, we've got time for a couple of questions, and Liesbeth, I might bring you in too. The first question maybe to you, Ole, do we really need a large bore closure device? And we've got ProGlide. Liesbeth's going to tell us how great the multi-close algorithm is, but do we really need this? Is this something that we only need for bailout, or do you really think that if we got a good device that could do most cases for us, that this would make us safer, make us more efficient?
Yeah, it's all about if we can obtain that reliable hemostasis at the end, relatively quick, reliable, and we don't need any pre-closure, for example. That in a world, that could be the ideal world. So why not? I think we have to keep on searching for the ideal closure device, and maybe we have to come away indeed from the idea that it has to be able to be used on all comers population. Maybe we can cherry pick. We can say, okay, this patient looks really great. There's absolutely no calcium. Vessel size is large enough. Here we go for this quick and easy vascular closure device. If you have a more challenging case, you adapt to the situation. I think that's one of the, if you're a physician, that's one of your skills you have to develop. It's taper the treatment to the patient you have in front of you. So maybe we have to come away from this idea that one device, it has to be able to fix it all and to treat all the patients and give a perfect closure in all your patients. No, maybe we can taper it to the needs what we have, and then I think there's definitely space in getting a device which is easier to use and even more reliable in getting more complete hemostasis right away.
Okay, and Liesbeth, maybe a final quick question to you. Are there particular patients who have challenging access anatomies that you think that would work really well with a particular closure device? Is there a particular group, I don't know, obese patients, for example, calcified patients that you think might be suitable?
It's always looking at the whole part, because sometimes they're obese with no calcium, sometimes obese with calcium. Sometimes they had a previous hip replacement, and then you have a lot of fibrotic tissue as well. So yeah, you need to tailor your device when you have very calcified, a lot of calcifications at the site where you know you will need to do the puncture sites in an area with a lot of calcifications. You might need to prepare that your closure device will fail, and then you need to have upfront strategies to bail out these.
Okay, so Liesbeth, you're going to take us through the multi-close algorithm and your recently published study and your intervention. We've started adopting this approach recently, and we found that we're quicker, we're more efficient, we're using less kit. Take us through it and tell us about the results of your study, and maybe some of the people, our colleagues online, can ask you some questions via the chat box.
Okay, great. So it's really a pleasure to show you these results of this multi-close study. And for starters, I want to say that this multi-close study, wait, my slides. Yes, so here you can see the scheme of the algorithm, and we'll go through it in detail in the next minutes. But first of all, I want to say that this study was not really set up to compare different vascular closure devices, but no, moreover, it was the introduction of this algorithm or this framework that we create, where we can have a stepwise approach, and depending on the situation that we're in, we can deliberately choose for our next strategy. So this creates a clear framework to do your closures of your large bore femoral access cases after TAVI in this study. So I'll just guide you through it in detail. We go to the next slide. So for every case, as in every case, we will go for a good and a conscious pre-planning. So we start with the CT, and here we look, of course, to the iliacs, the femorals. We have a look if they are tortuous, the calcification amount, the calcification distribution. We also look to the depth of the femoral artery and the heights of the femoral bifurcations. Also, at this moment, we'll already think about what we would need in case of a non-hemostatic case in the end. So we also already look to the size of the balloon that we might need, or a covered stent. Then we go into the cath lab, and within this algorithm, it is foreseen that you do an ultrasound guided puncture. I think most centers nowadays do this. And the moment that you puncture your artery, and you will go in with the needle, you introduce your short wire. We take a few seconds to drive the table to the groin, and we do a short fluoroscopic image. And here you can see in this example where the artery really punctures the artery vessel sides. And this is important for later. We might need this in the end of the algorithm. So here we're now in the cath lab. This is a picture of our usual setup. So we have in the left groin a needle in the skin for our pacing on the wire. On the right radial artery, we have a 6-French sheets for our balloon, for our pigtail catheter, which we'll use for monitoring and contrast dye injections. And then on the right-hand side, we have done the ultrasound guided puncture and inserted our 6-French sheet. At this moment, we will introduce the vascular closure, a suture-based device. So in our practice, we use a single Pro style now. I have to say in the beginning, when we were doing the algorithm as well, we were using often 2 Pro styles, but for the moment, when we have a good tactile feedback and it feels like the one Pro style is well introduced, we only use one anymore in daily practice now. Of course, then our attention goes to the implantation of the transcatheter heart valve, and we hope for a good result over there. And then we go back to our algorithm. So now, in this case, we had a sheetless valve was inserted. So we have replaced it over the stiff wire with a 14 French sheet. It was in this case. And we keep this 35 wire in situ. And we will remove the large sheet while we have with our will push the nuts of the Pro style with a nut pusher. You see on the right-hand side is the operator. On the left-hand side is somebody just touching the groin just to have not too much bleed back. At this moment, either you have overt major bleeding, this is in a minority of cases, but at this moment you could already step out a little bit of the algorithm and go to a large plug vascular closure device. But luckily, in the majority of cases, we can have the next step. I don't know, my slides are moving. So we can go over to the next step, and then we follow our algorithm. So if there's no overt bleeding at this moment, and the next step would be to insert now a 6 French or 8 French small sheets. You can see that we still have our wire in situ. So up until now, we are still safe. In case we have a major bleeding, we can still introduce a large bore sheet if needed, just to tamponate any bleeding. But at this moment, we have introduced our 6 French sheets, and this gives us some advantages because we will use it for the angiogram, a direct angiography, we can avoid the need for a contralateral injection, which is actually quite time consuming. It also takes a lot of extra radiation. So this really speeds up the process. Next, the moment that you have this sheet in situ, and you still have some extravasation, if you would still see some extravasation, I'll go back one. Yeah, this is the moment where you once more can tighten the knots of the pro style, because you have now this little sheet gives a bit of a backbone. So, for example, in very obese patients where you would advance the knot pusher of the pro style, you actually end up of just pushing some soft tissue, but not really the nuts. So this is really an advantage with having this small sheet in. You can really push once more the nuts, and you have this backbone nicely pushing the nut really onto the vessel. And then as a next step, we will deliver some contrast. Very often just 5 milliliters of contrast is enough. And then we look to this image. So first of all, we'll have a look of, is there any extravasation of contrast time next to the vessel? In this example, we actually see no leak. So at this point, we could either decide not to put any additional closure device, or we add 1 6 or 8 French angel seal. In the second situation, we have on the left side, you can see some mild leakage beside the sheets, or on the right side, you can see more a moderate leakage. At this point, you can decide to either put in a 6 or an 8 French angel seal, or what you also could do if you think the bleeding is quite a lot, you can insert a new pro style. If you want, again, you can do another angiogram, and if needed, you can do another. You can even add 1 angel seal after this. Here you see a picture where we have introduced the 6 French angel seal over the wire. At this moment, we will take out our wire. So this is the last moment where we have a wire through the arteriotombocytes. Now, in the third situation, when there is really severe leakage next to the sheet, this is the situation where we will go to a large plug-based closure device. So in our practice, we have the Manta system available. Now, one of the maybe disadvantages of the Manta is actually you need to use this depth locator at the beginning of the procedure to have a deployment, to know your deployment depth at the end of the procedure. Now, in this study, we also explained a little how you can overcome this when you haven't done your pre-measurement, because upfront you didn't want to use the Manta device, for example. And here we have explained how we can manage this. But maybe we can go into that later on. Now, I'll just show you some of the results of this study that we have done. So there were 3 participating centers. This was done mainly in Copenhagen and then in 2 smaller centers in Belgium. And there were 630 patients included in the study. Let me just go back. Yeah. And of note, actually, patients that were not included in this study were only patients that had, for example, a safety wire in situ from the contralateral side, for example, that in cases that had some kind of PTA or intravascular lithotripsy. So those patients were not in the study, but actually 95 to 98% of our whole cohort was in this study during the study time. So it was an all-comers, quite all-comers situation. The mean age of the patients was 79. The average BMI was 26 and the Euroscore was 2.2. In the study, it was mainly different types of self-expanding heart valves, transcatheter heart valves that were deployed. And the sheet sites were in half of the cases, 52%. In 52%, it was a 14 French expandable sheet. A good amount of the cases also had the inline sheet methods, also 14 French, but even 16 to 20 French cases were included in this algorithm. you can see that the contralateral access was only 1 in 10 through the radial artery. This has to do because quite a lot of patients had a cerebral protection device through their radial artery. In those cases, they used the other femoral groin to do the secondary access. Now, if we have a look at the results, so in 3 and 4 cases, there were still 2 ProGlides implanted upfront as pre-closure. This is still quite a lot, and this doesn't really resemble our current practice anymore, but this was also mainly at the beginning of the study, and by the end of the study, we saw that there was much less 2 ProGlide technique. Now, in those cases, the majority of cases had 1 angiostele on top of 1 or 2 ProGlides. Then there was 4% of cases that did not have any additional vascular closure device on top. 1% had an additional ProStyle, and in 2% or 13 cases, a large plug-based device was used. Now, in 14 cases in total, there was need for a bailout strategy that hemostasis was not achieved through the algorithm. So this is 14 cases in 2% of the study. And in those cases, one time there was a balloon used to reach hemostasis. In 12 cases, it was a covered stent. And unfortunately, in one case, there was surgical repair of the vessel. Now, this makes for the whole, if we look to the whole amount of vascular complications in this cohort of 630 patients, that we had a minor vascular complication rate of 2.2 and a major vascular complication rate of 0.6, which is indeed below the 1% that Ola wanted to reach. So we concluded with this study that the algorithm that we introduced is safe, effective, and was also easy to implement. As we started doing it in the 2 smaller centers in Belgium, we saw that this was quite easy to implement. We have reached the major complication rate of below 1%. And we believe that actually the success of this algorithm is that we build in the possibility of multiple safety nets at multiple moments during the closure strategy. And these were the results.
So Liesbeth, thank you for that. That's a very clear presentation on this algorithm. You know, again, congratulations to yourself and Ole and the other investigators for this approach. We've adopted it. And my favorite part is that you keep the wire in place. And so you have options at all stages to add more percloses, to reintroduce the large bore sheath. And I think you're right, you save time. Our secondary access is radial in most cases, and we used to spend time coming down from the arm, bringing the long multi-purpose and do an aortogram via the left radial, and it takes time and it takes x-rays and contrast, so you've made our lives easier. Let me ask you a couple of questions. In terms of the possibility of the bailout manta, do we have any evidence that this actually works, that this is good practice? What are your thoughts on that?
Yeah, so with this, in our study, we introduced 2 possible methods to do a bailout manta. There was actually a recent publication in Eurointervention where they also suggested a method to do a bailout technique without having the pre-measurements stick available. And yeah, we have to say we did see some failure after manta, so it's good to have it as a bailout. But for example, in this other study, 8 in 10 cases, the bailout manta was good, but sometimes you still have a residual bleeding after the bailout technique. But it's good, again, to have it because it's already a smaller group where you need to bail out with manta. And even in those cases, very often you achieve good results.
Okay, so if I understand that study in your intervention from Mohammed Abdel Wahab and his colleagues, in Leipzig suggested that about 80% of cases can be successfully closed, bailed out with a MANTA, with about 20% of cases where the device is implanted too deep or too superficial, and therefore it's not effective. Ole, you're going to teach us a little bit about the PerkSeal device from Vivasure in a few minutes, but is it possible to bail out with this device? Are there any advantages to that particular product?
Yeah, it's definitely possible. I haven't used it for that, but an additional advantage I would say with the PerkSeal, as I will show you in a couple of minutes, is you don't need any pre-measurements. So this is not needed. So with MANTA, indeed, you need, as you know, there's a ruler. Before you go in with your large bore introducer sheet, you have to kind of measure the skin to artery distance. We could, in the algorithm that Liesbeth presented, the MultiCLOSE in that study, there is described a way to go around this. But that's not needed at all with the PerkSeal. So PerkSeal, you just go with your puncture, arterial puncture, you upscale to your large bore introducer sheet, you do your case, and only at the end, then you just measure your distance and you introduce your introducer sheet from your PerkSeal vascular closure device, and you continue. So there's nothing been needed beforehand. So that's an additional advantage.
Okay.
And of course, then it could also be used as a bailout, because the thing what I think is important there, if you want to use this kind of bailout technique, and if you use this MultiCLOSE algorithm, it's been described by Liesbeth in her article, is that she keeps a stiff guide wire in place. So if we do the closure, she retracts the introducer sheet, she pulls on the one ProGlide, she reintroduces a 6 or an 8 French sheet. On that moment, we still have the stiff wire in place. And the good thing is, by keeping this stiff guide wire and at this particular moment still in place, is that if, let's say, you pull on your ProGlide and you pull and you see that you have the knot in your hand, you don't have any ProGlide in place because you went for the single Pro style or ProGlide's technique, there's no stress. You have your stiff wire still in. You go either in with your large introducer sheet, or you can go immediately in with your MANTA or PerkSeal, for example. So you will always maintain and keep your access. Whereas if you have just a regular J wire, you've been in these situations where that J wire kind of gets into an S shape, you lose your access, you don't get in anymore. So I think keeping that stiff guide wire in is also a small key to the success of it, if you have to do something additional.
Perfect. So Ole, you've answered one important practical question I had about the algorithm. Liesbeth, I've got one more for you. In terms of the single PerkCLOSE, are you leaving that right in the center of the vessel rather than the 20, 30 degrees left or right? What's your practice?
Yeah, so no, now I always aim for only one per Pro style, and I really do it just at 12 o'clock, I would say, not at 11 and 1 or 2 and 4. So we just aim like a normal, like this also suggests in the IFU, just a normal 12 o'clock pre-closure.
Perfect. So Ole, why don't you take us off to the third and final presentation, where we're going to learn a little bit about PerkSeal from Vivasure, potentially the future of large bore closure.
Yeah, thank you, Darren. So this is indeed specific about the PerkSeal device. You see a picture, an illustration of it on the right-hand side. So this is a single-use device, of course, for 14 to 20 or 24 French large hole closure. It's a fully bioabsorbable and a patch-based closure. You see an illustration of that patch, which is really flexible. If I've had it in my hands, it's very flexible. It can adapt to the convexity of the concavity of the vessel, and so there's no long-term artery pinching or abrupt artery closure. Also with the deployment of the device, so that's a potential advantage. There's a closure, it closes from the inside, and that's in fact really interesting. If you deploy the device and you actually only deploy the patch and then you retract the patch to the vessel wall, you indeed see that you obtain full hemostasis. That's also the proof that your patch is sitting on the correct side, but on that moment you didn't lock your patch in place, but that shows and proves indeed that it's fully depending on the patch to get the closure, to get the hemostasis. But because of this, because it closes from the inside, and not so much from the outside with just a collagen plug, for example. It minimizes the bleeding into the tissue tract. So there's lower rates of hematomas and also pseudoaneurysms. As I said before, it eliminates the pre-procedural steps, so you don't need to do any pre-measurements skin to artery. So that also, if you think about, for example, closing an impella later on, etc., this is an ideal device also for this. And it's a simple and controlled delivery. So I would say it's a very short learning curve. So if we go then here a bit more into detail about the patch, so it's fully absorbable. This patch seals from the inside, so different from the other devices. It's a single material synthetic implant, very low cross-sectional profile, and it's a textured abdominal surface, as the company calls it. So there's no sutures or collagen or metal components involved in this, and it absorbs within 180 days. That's also important. If you have to do kind of a redo procedure, for example, a couple of years later, there's no problem going through this access again. So you have two components on the left-hand side. That's the device. That's the device with the patch at the end, and then you have the delivery sheet on the right-hand side of the slide. So this sheet is the first component to introduce, and then I will show you immediately from this video. So here the 18 or 16 French sheet comes out. I think this was a 16 French. So this goes out. You keep your stiff wire. This is just an unplugged super stiff wire. Now this is that sheet from the PercuSeal, which is soon arriving. So that's here, coming. So it's a sheet with a dilator inside of it, with also a ruler, so and a centimeter indication on the sides. So what you do is you keep the flush port on the side, you keep it open. I will show it here very soon. You will see it in the video. So here the flush port comes. So then I introduce this introducer sheet from the PercuSeal until I see blood coming back, yes. And then I retract. So here you go. So this is a good bleed back. I pull back, I retract until it stops. Here I stop, then I read the distance. Then I read, for example, this is 3 centimeters skin to artery. Okay, 3. Then on that moment, you advance 4 centimeters further in the sheet. Okay, so 4 centimeters further in. Then you take out your dilator. Then you come with the device here. This is nice on the illustration. You click it together. That's the small component that captures the patch, and then you click it together. So the patch is ready at the end of your sheet, which is now 4 centimeters inside the vessel. The next step to do is you turn the first knob clockwise, and by doing this, you actually just retract the sheet. So the patch comes free into the artery, as you see here on the illustration. And then after that, you retract on the device. And this is some tactile feedback. You feel it clearly when the patch hits the vessel wall, but I've done it in the cases I've done. I've limited experience with this device, but the times I've done it, I've always used echo. And you see actually very nice this patch on your echo. You see it as a very echogenic white structure. So it's very elegantly on a 30 to 45 degree angle, you retract it, and then until you see the patch going very nice, opposing against the top of the vessel wall. And then you stop and you see, now I'm just having this small traction on my device and there's no bleeding anymore. So this is just by pulling on the patch, softly pull, softly traction on the patch, and it closes immediately. So you have an immediate complete hemostasis. Next, what you do is you click, and then by clicking, you can turn on the second knob clockwise. What happens with this second knob? Well, by turning the second knob, you lock the patch in place. So there comes another component from outside the vessel, which locks itself on a small pin that comes out of the patch. There's no, as said, no metal involved in this. This is all bioabsorbable material, and it clicks so that the patch stays in place. So you see me doing this here. This is the second knob. I keep this device in place, and I turn it until it makes a small click. Okay, so I've done this. So then, in fact, you're almost done. So it's very easy. The next thing to do is retract the wire. And then after retracting the wire, you can close this lumen for the wire and just retract your device. So that's what you will see here. Then you detach, so the locking mechanism stays on the patch. So you see me doing this here in the lab. So I'll turn this last knob, and then indeed I'm very careful in retracting it in the same angle as the locking mechanism is itself. And then you see we have an immediate hemostasis, and here I do a control, echo control. I don't make an angiographic control. I just look with echo. I see the patch nicely in place. I see no extravasation, no pseudoaneurysm. I see a good flow, no stenosis, and then you're done with the case. Okay, so this is how you deploy this PerQseal device. I would say it's very elegant to use it. And then here, this was still an angiographic control. We did because the patient was in a study, in the elite study. So we still did it but it would not be needed. But you see, you have an immediate nice hemostasis there obtained. So that's it, Darren. So here you see, this is an illustration, the patch from inside, how it looks. And then, of course, it bioabsorbs within roughly 3 to 6 months. Then it should be disappeared. Then you have restored the artery to its original status again. So this is, as a conclusive slide, it's a repetition. I think it fulfills a lot of criteria we want from good closure or contemporary closure devices. It's easy to deploy. It eliminates a pre-procedural step, so it means you can go quick. You have low rates of hematomas and pseudoaneurysms. You have the closure from the inside, which is also an additional advantage. And it leaves a very small footprint behind, which we also want, especially because we treat younger and younger patients. Maybe we see these patients in a couple of years from now again for a redo intervention. So we don't want to leave there a covered stent or something, a large footprint behind, which would complicate a new access of a large bore in the future. So the word back to you, Darren.
Super. Thanks, Ole. If I can ask you a couple of questions just on that technology, and then we're going to switch over to some of the participant questions. The elite study you mentioned, tell us about this. When are we going to have evidence of safety and efficacy for this device? When is it going to be commercially available?
This is a study where they include, it's about 100 to 150 patients led by PI Nicolas van Michem. There are a couple of sites already enrolling. I think the enrollment is going good. So in a couple of months from now, maybe by summer or shortly after summer, I think we hope that all the patients will be included. That's to get the CE mark approval also. So I think by the end of this year, hopefully, it could be available to all of us, hopefully.
And a quick question in terms of the wire being, I suppose, remaining in the vessel. Can you use that to your advantage? Is there a point at which you can take the device out and keep the wire in place if, for example, you had residual bleeding and the patch wasn't working in a particular case?
Yes, indeed. So that's also, I never came into that situation so far in the cases I've done, but indeed, if you go in with the device, even if you deploy the patch and you pull back on the patch and you would buy the pullback, that's your moment of verification. If you would see that you cannot obtain good hemostasis, there is a technique to twist it and get the device, pull it out. You have your stiff wire still in, and then you can think of other methodologies, techniques to indeed get your closure. So indeed, that's possible.
Yeah, that's a nice advantage of this system, the maintenance of the 035 wire. Huh? That's a real plus.
Yeah.
Liesbeth, we have a few questions for you. Jawad Zaman wants to know, in your opinion and given your experience with MultiCLOSE, what's the best technique for a patient with calcific disease, be that on the anterior wall or the posterior wall? What do you guys do in Aalst?
I would still go for pro style and use this algorithm, because when it's calcified, we know we have more chance for vascular that the pre-closure won't work in the end, and we still have our different steps to bail out in a very controlled way. So I would still go for a pro style technique.
Okay, and would you, for example, if you had more calcified disease, would you go up front with 2 PerCLOSEs in that particular patient, or would you stick to your current practice and just use 1? Even
now, I stick to my single ProGlide technique when I very good tactile feedback on the first one, I will not deploy a second one. And this is maybe a rather subjective thing, because in our study also we saw that in the cases where we had 2 ProGlides, we actually had a little bit higher complication rate. This was not significant because the numbers were too low, but you can imagine that it's also not designed to deploy 2 ProGlides to each other. So maybe sometimes they can interfere, or just the fact that you deploy 2 can give some problems. So in that way, it's not a strange way to do it, but in that sense, it does make sense to only deploy 1 actually.
Yeah, sometimes they can interact with each other for sure. You can see you pull on one and you get more bleeding, you pull on the other and you get less. So I've had that experience too. A question regarding the use of a single device, a single Pro-style device from Freddie in Argentina, saying that they use a single device and seem to have good experience with that. What proportion of cases, Liesbeth, are you adding the extra angio-seal?
I am personally adding, I have a very low threshold to put in another, to add on the angio-seal in the end. But very often when you do your final your angiogram, you have very nice hemostasis. And then you think like, I don't need to put another device in. But just also for the quick ambulation of the patient, I like putting on another angio-seal, that you don't have any oozing afterwards when the patient's in the room, that the nurses start calling you. So that's one of the reasons why I would still deploy an angio-seal on top.
So an easier life from your nursing staff is worth an extra angio-seal, is what I'm hearing. I have the same experience. Ole, a question from Oran Shala regarding hemostasis time. In your experience of these different devices, be that with the MultiCLOSE algorithm, the MANTA, and now the PerQseal, what's the hemostasis time with these different techniques? What are your thoughts? Obviously, it can vary from case to case, but in general, which do you find is giving you the quickest time to hemostasis?
I think my rule, I'm becoming less and less forgiving on that question. So what now? My approach is really, I will not leave the cath lab, or my patient will not leave the cath lab if I don't have immediate full hemostasis. I don't want to send a patient with somebody compressing on the groin, or even worse, with some pressing bandage around this groin. No, I want immediate hemostasis because it's a mechanical thing. You want to get the full hemostasis. So that's why, indeed, if you do the single ProGlide, maybe it's enough, but very often then you need 10, 15 minutes compression still on the groin. To be honest, it's all about then, do you have the personnel, the nurses for that to do that, or we don't. I mean, so we prefer to have the full secure the full hemostasis, complete hemostasis on the table. With MANTA too, with MANTA and or PerQseal, I would say PerQseal as well. In the cases I've done, you want to get to full immediate hemostasis. You don't want to stand there compressing 10, 15 minutes on the groin. So I think this is something I learned, because sometimes if you have, then you send the patient to the department with somebody compressing. That's still in these cases where sometimes you take a risk and something may happen, either a stenosis then or bleeding, or it's better to verify in your lab before the patient really leaves, to have complete hemostasis. And I think there, for example, PerQseal is really nice because you can have it while you're deploying the device. You have the feedback immediate. Do I have immediate complete hemostasis, yes or no? You can see it.
Perfect. And a final question from Amit Kumar. Maybe I'll answer this one. Amit is wondering about complication rates with PerClose or suture-based closure versus MANTA. The choice closure study published in Circ last year demonstrate approximately twice the rate of vascular complications with MANTA compared to a PerClose-based strategy. Having said that, most of those were minor vascular complications, Amit. Many of them small hematomas, pseudoaneurysms, no big difference in terms of major vascular complications. So I think, again, all of these strategies are worthwhile. So we're coming up on the hour, and maybe to conclude, Ole took us through the landscape, if you will, of large bore closure devices from the early phase of using ProStar and the horrendous vascular complications, both major and minor, that we used to experience in the early days of TAVI, right through to the multi-close algorithm, where Liesbeth showed us less than 1% major vascular complications, and in my experience with this algorithm, many less minor vascular complications and more efficacy and efficiency within the lab. We also went through the new PerQseal device from Vivasure. We saw that device has particular advantages that may relate not only to closure of all arterial accesses. The company are also planning on bringing that as a venous solution for large bore venous access, though personally I've no experience with that yet. But Ole showed us a nice case, and his experience to date certainly seems positive. So with that, I want to thank Liesbeth and Ole for joining us, for your expertise and spending your time with us this morning. I'd like to thank Vivasure for sponsoring this session, to the faculty of TIO for your support in developing the session, Radcliffe, who are Zooming to you live, and to encourage you all to enjoy the rest of TIO over the next couple of days. It's only getting started, so enjoy the remainder of the sessions. Thanks for bearing with us over the last hour.